Hello, everybody. Welcome to the So You Want to Be a Surgeon webinar, hosted by the Royal College of Surgeons of England. My name is Laura Hamilton. I'm a council member and an orthopaedic surgeon down in Brighton. So this evening, we're going to talk a little bit about the general pathway to being a surgeon. We're going to talk about tips and tricks of accessing training and improving your portfolio. We're going to talk about research opportunities, alternative pathways, and different support networks that you can access. So during the chat, during the webinar, you'll see a little button at the bottom that has live Q&A. So during the presentations, if you have any questions, if you could just type them into the side, I'll keep track. And then at the very end, we'll go through them and answer as much as we can. If there's someone in particular you want to direct the question to, just put that in the notes so that we know who you'd like me to contact. So I think we're ready to go on the first presentation. So next slide, please. Oh, so sorry, just go back a slide. Thank you. So these are the people who are presenting today. So we have Fran, Sri, and Val. And I have checked, and I am allowed to call them by their first names, which I normally hate when presenters call women by their first names. But they're all very friendly and nice this evening. Okay, next slide, please. And next slide. So this is just a basic overview. We're going to go into this in a little bit more detail. The path to being a surgeon, it's relatively straightforward now. It used to kind of wind around lots of different roads when I was in training, and we'd go off and do all sorts of specialties. It's quite streamlined now, and it's quite a clear path set aside for each different specialty. You don't have to decide straight away you want to do surgery. You don't have to decide what type of surgery you do. You can try lots of different things and see what suits you. Chris Whitty in particular really wants people to try lots of different specialties. He thinks that we gain a lot of experience learning how different people do things. Even as an orthopedic surgeon, I occasionally remember techniques from when I was doing vascular surgery, transplant surgery, and things do pop into your head that you've picked up in other specialties. So don't feel like you need to decide straight away and just stick at that one specialty. So you can see you progress through what we used to call the house officer years, the SHO years, and then the registrar years. The different specialties have a different length of time. A lot of specialties expect fellowships at the end as well. So in orthopedics, we'd expect at least 1 year of fellowship after you get your certificate of completion of training. And hand surgery that I do quite often have 2 years of fellowships. Most people tend to just do fellowships until they get a consultant job. So it could be a bit longer than this. The other thing I'd say is that a lot of women do take time out. I took about, I think, 19, 20 months in total for babies and maternity leave. So I was a little bit older than the rest of my year by the time I finished. Otherwise, people take things out for caring responsibilities. People take sabbaticals. I've got a friend who did some academic work for a year, another friend who worked for GlaxoSmithKline to make some cash. So there are lots of ways that you can take a break from this pathway if you need to. The other thing to say is that alongside the traditional training route, you have the SAS route or the trust grade route. And again, that's just as valuable. As long as you're hitting your milestones of audit, research, numbers, and experience, it doesn't really matter whether you're in a training program. The main difference is the training program push you a lot harder. They force you to keep on top of all the goals. So it tends to be easier to keep up if you're in a training program than if you're doing this through self-directed learning. Okay, next slide, please. So surgery is a huge area. There's so many different aspects to it, so many different routes you can go down. You could be doing tiny fiddly things. You could be doing massive things with power tools, dealing with babies, dealing with bowel or brain or nerves. So again, once you decide you like surgery, that's not the end of the road. It can take quite a long time to try your way around lots of different specialties and see what suits you. And I think most people do it by talking to other surgeons who are in that specialty, seeing who they get on with, seeing who they click with, seeing what the priorities are for them and what makes them happy, and seeing if that ties in with their future. So lots and lots of different options. Next slide, please. So I just wanted to say a little bit about orthopedics. So it gets a bit of a bad rap. So orthopedics is the biggest specialty. So most people going into surgery will be doing orthopedics. Don't listen to what people tell you. Don't listen to the old stereotypes. Everyone thinks it's full of old white bros. There's lots of funny Twitter videos and things like this about ortho bros. They are very funny, but don't let that put you off. And that's the same for all the specialties. Next slide, please. So we did a study down in Brighton, asking people what they thought of orthopedics. And before they did the placement, they thought they were unfriendly, sexist, aggressive men, basically. And then once they did the specialty, once they did the job, they realized actually everyone's very nice. There's lots of women, there's lots of different minorities and diversity, and everyone was friendly and kind and welcoming. And everyone who'd done the orthopedic placement kind of wanted to do orthopedics. And I think the thing is that sometimes you're listening to people who did orthopedics 30 years ago, and it was very different 30 years ago. And I think that's the same for all the surgical specialties. So try not to be put off what someone who's a bit older tells you you can and can't do. There's a lot of students who have said, oh, you can't do orthopedics because you're not tall enough or strong enough, or you can't do pediatrics because you're too loud or not soft and gentle enough. There's lots of funny little sayings. So don't be put off with that. Just make your mind up for yourself when you actually experience the specialty. Next slide, please. And this is actually orthopedics now. We've had lots of female presidents of the British Orthopedic Association. Lots of the SAC leads and the orthopedic leads are now women. Sam Hook is now the lead of the STG, the selection design group that I'm on, that appoints the next generation of orthopedic surgeons, and she's female. So it's very different to how it used to be. So try not to be put off by old stereotypes and just look at things with a fresh point of view. Next slide, please. So this was my journey, just to give you a kind of an idea of how long things take. It is a slog. I think it is a lot longer for most surgical specialties than something like radiology. My best friend at uni was a radiology registrar when I was still a first year SHO, and he was a consultant when I was halfway through my registrar training. So there are quicker ways to get to be a consultant than surgery, but they're not as fun. This is the best job in the world. We have so much fun. Every day is a school day. Every day you're learning. Every day you have a challenge. You have to think on your feet. So you have to know your stuff. You have to work hard, but it's really, really fun. I don't know many people who look forward to going to work, and most surgeons do enjoy going to work. So these are some of my ID cards, which I found in a drawer. I seem to have been an SHO for years, I think, because this was before the run-through training. So there wasn't really any structure. So I kind of meandered around lots of different specialties, but I always wanted to do orthopedics just because it was fun and power tools. But I did try lots of other things. And again, they give you experience. Next slide, please. And this is me getting my FRCS. I'm very cool, as you can tell. I probably should have done a nice photo as well, but I was just so excited to finally finish. I only did a silly photo. Next slide, please. Okay, so we're going up now for, I think this is going to be Val, who's a plastics trainee, who's going to talk about a huge worry for a lot of students and trainees. There's a lot to get through, so I will hand over to Val now. Thank you.
Thank you. Thank you for the introduction and such an inspiring presentation. So hi, everyone. I'm Valdana Colidito, or simply Val, ST4 in plastic surgery in Thames Valley, and also I'm part of Association of Surgeons in Training, or for a short, ASIT, and I'm part of the executive team member and work as Associate Honorary Secretary for the team, meaning I work with industry and the partners with the association a lot. And today I'll share a few insights on how to build a competitive surgical portfolio, but more importantly, how to make it a reflection of your growth and not just the checklist, and how to access training opportunities best. Next slide, please. So my path into surgery started back home in Lithuania, where I studied medicine before moving to the UK. Like some of you, I didn't have everything figured out at the start. I just knew I loved surgery. The time would stop for me in theaters whenever I'd get to scrub in or assist in any case and put any stitches in. The transition into the NHS wasn't always smooth, but every challenge as I progressed taught me something valuable about teamwork, patience, and resilience. And also, I learned a lot about myself as a clinician and a person. Throughout rotations in general vascular, trauma, and plastics, I met mentors who changed how I saw surgery, and they inspired me more to achieve more, strive more, and progress. They showed me also that surgery is not just about the technical skill, but it's also about the attitude, consistency, and how you treat the people in the process. That's also what pushed me to get involved, teaching students, peers, and leading research audit projects, and also working with ACID. Each experience opened up new doors and helped me grow both as a trainee and a person. So if you're starting out and things feel a little bit uncertain, that's okay. None of us have it all sorted out early on. The key is to stay curious, say yes to opportunities, persevere, and keep learning as you go, because that's what really builds your portfolio and your confidence over a course of time. Next slide, please. So this is something similar to the slide that you saw just in the earlier presentation. This is a training pathway into plastic surgery specifically. It is useful to understand where you're heading from foundation to core training, then specialty and beyond. But honestly, what matters most early on is building good habits. Logging cases properly, i.e., the experiences that you gain in theatre, reflecting after a clinic or a list, and finding the mentors who can support you and help you grow as a person and give you some valuable insights into your training opportunities. Everyone's journey is very, very different. So it's not for you necessarily to compare yourself to a different person, because you may have different opportunities come up to you that you may want to explore, such as out of training research opportunities or different experiences. Maybe you're interested in global surgery and you want to take some time out to explore those options. Or maybe you're interested in medtech and would be interested in venturing out in those ways, or advocacy opportunities in terms of improving surgical training. Some people are specifically interested in just surgical exposure, and that's the most exciting part for me in my job. And I'm carrying on currently as ST4 in plastic surgery. Still don't have a subspecialty interest, but as you can see in the slide, there's so many different subspecialty areas to choose from just in plastic surgery. But equally, every single surgical field has got their own subspecialty fields. And I saw that there was a question in the chat about what is a fellowship and how does that differ in terms of the regular job that we do. So fellowship level jobs are usually the type of jobs that we undertake as we get closer to our consultancy level, meaning that we have maybe a certain interest in an area that we'd be interested in. Plastic surgery example would be lower limb trauma, lots of collaborative work with orthopedic surgery. So we'd take an extra time to develop in-depth knowledge into lower limb trauma and reconstructive options. So this is more in terms of gaining more experience in a specific field. That can be done in UK or outside of UK, and some of the fellowships can be completed right before completion of your training, provided that you've progressed far enough and are ready to undertake your subspecialty interest fellowships. Next slide, please. And some of the important key messages that I'd like to mention before I go to more into nitty-gritty detail of what portfolio is specifically for a CST application is that surgery is a marathon with hills, not a 100-meter dash. It is tempting to compare yourself to others, but your portfolio should be a story of purpose, not just competition amongst your peers. Collect the evidence, reflect on your learning, and remember that consistency always beats intensity. Best surgeons aren't remembered just for their CVs, but for how they taught, empowered, and healed. As you progress through your career, I encourage people to mentor someone, include others, and share the credit. Surgery is high pressure, but you don't have to lose yourself to succeed. It's a false stereotype. The ones who thrive long term are grounded, kind, and know why they're there for the patients, for progress, for a presentation. And it's the purpose that keeps you going. Um, and now going more into competitive portfolio details, things to be aware about is that there's a ever-going change in terms of how trainees are assessed. When I applied for core surgical training, the scoring was slightly different, but it doesn't mean that people get really stressed about this and overwhelmed with the changes in the portfolio process and scoring. But I feel that most of the trainees or medical students who have consistently worked and progressed their portfolios, not necessarily aiming for specific points, they still do absolutely fine and get their desired posts. The reason the processes are reviewed and how things are scored changes is to make it easier in a sense, and also to select the best candidates and to possibly avoid cherry picking. I'm not the person who creates these points, but I'm just trying to create a rationale of why these things are done. So how it is scored at the moment is that your portfolio station score for core surgical application, core surgery training application specifically, is 45%. Your management and your clinical station score is 45%, and your multi-specialty recruitment assessment exam is 10%. And you can understand that portfolio has got quite significant weighting in terms of where you rank and whether you'll get your desired job or no. And as I mentioned before slightly, the key is to start early and document everything. Even small achievements do really add up. And as long as you've got the evidence, even if the letter and the wording needs to be slightly changed, if you're the person who strives to be good and has not burned the bridges along the way, even if you need the letter changing slightly, you'll be able to reach out to your registrars, fellow colleagues, consultants. You'll be able to support you in getting the correct wording for the letter, for the proof of your competence and the achievements that you've had in the difficult self-assessment bits. Next slide, please. So one of the most useful websites with the most accurate and up-to-date information will be on NHS England Workforce Training and Education, or where it used to be HE website. You can see yearly updates on the application processes, including the portfolio requirements of what is needed year on year. And there's very useful webinars held as well. There was one recently as well regarding specialty recruitment, including all specialties, not just surgery, but there's some upcoming ones specifically for core surgical training, more targeted at foundation year doctors. So this will be more technical information of what counts, what doesn't count, and you can ask questions there as well on their live sessions if you are unsure about the specific evidence and what would or wouldn't count. There's very useful webinars that I'll mention slightly later on in my presentation. Next slide, please. So the main domains that are currently assessed in the portfolio station are commitment to specialty, audit and quality improvement projects, presentations and publications, as well as your teaching experience. There has been a move away from leadership management courses, conferences, and awards and prizes domains, but they're in some ways also at the same time assessed as part of your audits, presentations, teaching experiences. So not to duplicate the amount of evidence the assessors have to go through, and pushing more for the focus of quality work that people striving to achieve CST posts. There's been a shift of focus essentially. And things to mention: the easier your portfolio is to navigate, the easier it is for examiners to mark the people applying for core surgical training. Examiners have about 10 to 15 minutes to go through your portfolio, and you actually have during an interview session a 15-minute slot to discuss and have questions asked about specific areas of your portfolio. So you have to know in and out your evidence, what you have done, and have some reflections about what has it actually achieved. Has it changed the way others practice? Like if you've medicine, for example, if you've implemented a great audit project or quality improvement project, maybe it has changed the way the department works, and in turn it has improved patient care. So that would be an excellent discussion point of what you can discuss about during your interview. Next slide, please. This is more going through the domains from the Workforce Training Education NHS England website. So what is commitment to surgery and how it is assessed? In terms of your operative experience, if you're interested in surgery, achieving 40 or more cases that you get to be involved in as an assistant is not necessarily hard. Observed cases do not count. But having gone through surgical training, I definitely, even before applying to CST, I got to scrub in and assist in more than 40 cases. It can be sometimes challenging to arrange depending on your foundation posts, but see if you can arrange swaps. But alternatively, you can look into arranging your taster weeks, which will contribute to your surgical experience, or if you undertake elective experiences in surgical specialty, that would definitely contribute to your surgical experience, and not just ticking the box, but also your placements will also count. But make sure that you've got the right evidence and that you reflect on them, whether it's just assisting, suturing, reviewing a post-operative patient. Work with your mentors, work with your supervisors, because reflection shows the maturity of your understanding, because being a surgeon and progressing as a surgeon in training is a huge privilege, being able to contribute to patient care from a surgical perspective. If you don't have eLogbook as a foundation doctor or even as a medical student, please do sign up. This is what we use to assess the cases, and this is what would be used as your operative experience assessment area. And you need to, once you've got your eLogbook and you've got your cases, make sure that no patient data in your consolidated report is apparent, and that's all mentioned how to present that evidence in the WT website, so Workforce Training Education website. Next slide, please. Next, carrying on with the clinical audit and quality improvement projects. Since I applied, there's been a significant change in terms of having specifically surgically themed quality improvement and audit projects. What are these projects? So essentially, these are the projects where, if you're talking about audit specifically, you need to have a standard, whether it is your local standard or national standard, and you assess how well the unit is performing against the standard. To complete the cycle, you need to perform a well-targeted intervention. What is the issue? What could be improved? Once that is implemented, you reassess whether your intervention has been successful, and hopefully it has. And ideally, you could present it at a local meeting and maybe even a national meeting, such as ASSET conference, because that would give you, first of all, good understanding of what audit is, what audit processes are, how to improve patient care, but at the same time give you excellent presentation skills, and also score you the maximum points in the core surgical training application process. There are some caveats in terms of you have to be the lead of the project. So if you came up with the idea, or your supervisor came up with the idea, but you have some few other team members involved, make sure that it's more down to the mentor to distribute who's responsible for the project, who's the lead. But just so you avoid unhappy team members or putting a lot of work but not getting the right credit, have those discussions early on, because if you want the maximum points, you have to be the lead in this project, because we want to encourage leaders presenting substantive change for the patient care being part of the CST process. You can be involved in multiple audit projects or quality improvement projects, but the ideal is that one good project done well is worth way more than 3 or 4 half-finished ones that don't necessarily lead to substantive changes. Next slide, please. Carrying on with the presentations and publications domain, it's ideal if you have some of the research and publication presentation experience. The maximum points you'll get if you've won a prize for presenting your research work, or if you've got a publication that is in a PubMed cited publication. Things to be aware of: good projects take a lot of time, sometimes around 2 years, 3 years. So starting early will be a good idea. It sometimes can be quite hard because some of the projects don't necessarily bear the fruit that you would wish. But it's definitely good to strive in terms of starting small. If you start with case reports or case series as a publication, that would be a good starting point. And there's good networks that I'll mention slightly later on in my presentation. Carrying on to the next domain in terms of teaching experience, which will be next slide, please. We want to encourage surgeons who are educators. And if surgical education is something you feel passionate about, rather than running ad hoc sessions as and where and when, which are still great, sitting down with more senior team members and thinking of a long running program, which may be still running after you leave, would be something that would be way more valuable. Hence, when you're applying for course surgical training, the highest scores go to the people who have set up a program that was running face to face. There was more than 4 sessions, and you delivered 4 or more of these sessions. But other activities are also really encouraged and do give you significant points. Next slide, please. So things to be aware of: make it easy for your interviewer or your assessor. Have a look at the wording at the NHS Workforce Training Education website in terms of what the specific requirement is. Consider using title pages and don't oversubmit the evidence. Make it neat and organized. Put yourself into the assessor's shoes. You don't want to be overwhelmed with 200 different pieces of evidence that are difficult to track. And do not overclaim for points. And think about when you're thinking about your portfolio, what would give you the most by contributing, not necessarily the least. You may have heard about the Pareto principle, but think about conserving your energy, not to burn out. Don't do multiple projects all in one go. It's all about planning. Carrying on with next slide, please. And main key tips. I definitely suggest joining the surgical societies. There's medical school surgical societies that are present and can help you out at a starting stage. There's StarSurge Research Collaborative, which is excellent and has got really high impact publications, and you can be a collaborator in those projects. Obviously, I'm part of ASID, so I'm a little bit biased, but we do have medical student representatives, foundation doctor ambassadors, regional representatives, and specialty representatives in the team. And there's lots of conferences throughout the year that you can contribute to. Attend the courses, develop the skill set in clinical setting, because it'll grow you as a clinician and it'll help you develop the knowledge. And get involved in not only just research projects, but also collaborative research, as well as teaching groups. And seek out mentors. Can be quite tricky. You may not click with the right people for first experiences, but I think it's about finding the right people for you. And in the clinic, whenever you're in a clinical setting, for me, I'll give you a slightly unusual example. As a medical student from Lithuania, I got an Erasmus grant given to me from my university. They said, that's fine, here's the money, you can sort out your placement during your internship. And I was seeking for experiences in the UK, and I sent loads and loads of emails to varying different consultants. Uh, Loads of emails. One of the consultants got back to me, and I was like, oh, great, I'll get to use my Erasmus exchange, gain experience in the UK. Really, really excellent. But then the consultant went quiet. I sent a follow-up email. I was like, oh dear, am I going to get to do my Erasmus exchange program? What I ended up doing, I went a next step further. I actually phoned up the ward, and I was like, is Mr. So-and-so around today? And he actually happened to be doing a post-take ward round, and he was dead impressed with my perseverance about getting this Erasmus placement sorted out, that I got everything sorted out very, very quickly and had amazing experiences, first experiences in the NHS. And yeah, next slide, please. Just to finish off, there's so many things available out there. I feel having had first experiences as an Erasmus exchange student in the NHS, I got an excellent advice to follow the surgical colleges, sign up with ASIT, sign up with the BMA, and sign up with any surgical societies that I see are doing exciting things out there. If you're more interested in research, SRS or Star Surge are something to definitely look into. ASIT will give you a more general breadth in terms of multiple surgical specialties and involvement. If you're at the point of where you're preparing for your interview, there's a few courses running very, very soon. So one of them being done by ASIT by some of my colleagues. So preparing for career in surgery and core surgical training, which will be held 1st of November. But there's also Royal College of Surgeons of England, preparing for your interview skills, which I've recently noted is also going to be held on 10th of December. So something to keep in your books. And next slide, please. Lots of opportunities out there. This is a major push for ASIT, I appreciate, but that kind of sums up everything. So remember, this is a marathon with hills. Don't burn yourself out, pace yourself. Planning will help you achieve the goals that you want, persevere, and you'll achieve what you want. Thank you.
Thank you so much. That was really interesting, Val. I deal with the ST3 applications, and it's actually very similar to the core surgical training. So the work you do now to get onto the core surgical training post is exactly the same evidence you're going to use to get your registrar job. So everything counts all the way through medical school. Even when you're going for consultant jobs, you can still talk about something you did as a medical student. Brilliant. So we have now Francesca, who's going to talk about some of the alternative issues and pathways that she's seen during her journey. Thank you, Francesca.
Hi. Thanks for the introduction, Laura, and thanks for having me. And so far, very inspirational talks. So I'll self-introduce myself again. So my name is Francesca Ferreira. I'm an ST5 neurosurgery registrar, also a clinical lecturer in neurosurgery at the University of Cambridge. And I'm also an elected member of the Royal College of Surgeons of England. So the title of my talk is From Overseas to Oxford. I have to be contrarian as usual, and I'm actually a clinical lecturer at Cambridge, but this is just an alliterative title to give an overall impression of what the career process to become a surgeon scientist involves. So I hope that you take some benefit from my experience. So next slide, please. So what is this talk going to entail? So basically my journey. as in a template that you can take some information or some experience or hopefully some advice from if this is something that you are inclined to pursue in your surgical journey. And what are the overarching themes here? I think it's opportunity, and as Val said, perseverance. I hate the word resilience, so you will not hear me say that. I think perseverance is a much more adequate word. And the importance of mentorship and also the challenges that I've encountered, and I think many people in an academic surgical academia encounter, and purpose of the career and the importance of finding your purpose. And the purpose of this talk is, next slide. Next slide. Next slide, please. Okay, so the purpose of this talk is to help you to learn to stop worrying and love the bomb. This. I like this movie. I like Stanley Kubrick, and this is a metaphor to say you will get a lot of ups and downs and some bombs along the way, but it's a wonderful journey, and it's a privilege to follow this profession. So next slide, please. So my journey is, I'm by origin, I'm Portuguese, so I was born and raised in Lisbon, which is in the bottom right of the composition. During my med school, unlike many people will tell you that they were born knowing that they wanted to do surgery, I wasn't one of these people. I knew that I wanted to be a doctor. I know that I had an interest in the brain, and everything else was sort of unclear. So I was very inclined to experiment and didn't have any strong commitment to any subspecialty. And I remember I did okay at med school, and I got a scholarship to come and do an elective in London in whatever specialty I chose. So I decided to do something in my head at that point completely, unexpected, something in my head that I might never do again. So I just wanted to see it. So I decided to come and do it in neurosurgery, and I loved it. And I was hooked. I was hooked on the science. I loved the technical aspect. I liked the fast pace. I liked the level of communication that you achieve with patients, the impact that you can make, and I thought it was all wonderful. So I decided to pack my bags and come and specialize in UK. My journey was certainly not linear. It was convoluted. I didn't get into neurosurgery immediately, didn't get my training number immediately, so I did core training in London. So as Laura was saying, I had a breadth of experiences in general surgery, doing hernia repairs, in vascular surgery, doing below knee amputations, and I think it was all a fantastic experience that really developed me as a doctor, as a surgeon, and as a human being. So I got my run through number in Liverpool. After that, I started developing more and more an interest in research, and decided at that point I wanted to do a PhD in functional neurosurgery, which is basically a sub branch of neurosurgery that uses certain techniques, but mostly deep brain stimulation, to treat a variety of neuropsychiatric conditions. So I went on to do my PhD in this topic at the National Hospital for Neurology and Neurosurgery. And following that, I gained a post as a clinical lecturer, which means I have protected academic time at the University of Cambridge, which is where I am now. Next slide, please. So I have to say, a transformative experience was my PhD, and also my master's. And my master's was a master's in medical physics, which was so far the most difficult thing that I've done in my career, because it's completely separate. So far, my training had been completely clinical. So in here, I learned neurocomputation, and I learned to code. And it was a wonderful but challenging experience, and it was a transformative experience that really fueled my passions for neuroscience and computational neuroscience and processing of MRI, and that opened a whole new avenue in my career. Next slide, please. So what I would say to you, if you're passionate about research, the first step is to, and this applies at every step of your pathway, even as a med student, find not so much a niche, but find a research topic that excites you, that you're passionate about, and get involved. Ask for a project, follow researchers, try and be helpful, try and engage, try to start at a basic level helping to write case reports yourself, have the drive, have the motivation, have the ambition, and have the belief in yourself. So I found a research niche, again, which is functional neurosurgery, and I won't dwell too much on the science, even though I would love to expose you to all of it. But ultimately, it's about using advanced MRI sequences to predict who responds to surgery, and also where best to target these patients in the case of various diseases like Parkinson's disease, essential tremor, and even psychiatric conditions that are refractory to medical treatment. Next slide, please. So, as I said, my career path was not linear, and I think it's unhelpful that a lot of the communications that exist portray surgical careers and surgical academia as some sort of like Ford like assembly line, and it has definitely not been the case. I've had multiple iterations, multiple loops, and like Laura, I have prolonged my career to an absurd level, and I also spent, I think, 5 years as an SHO or something like that. So I relate, and I think I didn't lose anything. Some people may disagree. I don't think I lost anything through that experience, and ultimately you need to keep the focus on the goal that you want to achieve, and just go through the motions, and just love what you do. So the typical career, if you want to become a surgeon scientist, let's say, get involved as a med student, find a topic that interests you, and then pursue the academic foundation program. That's a direct pathway into it. And then the natural progression to this is a academic clinical fellowship, and follow that a clinical lectureship, which is the position that I hold now. And then that, obviously, with some effort, may lead you into becoming an academic consultant. So next slide, please. So research, unfortunately, is heavily tied into, or the success of research, into funding and obtaining funding. This was going to become the bane of your existence somehow if you opt for this pathway. So this probably, you're all too young to remember this movie. This is a still from Jerry Maguire, where Tom Cruise could still move his face, and the quote is, "Show me the money." Which is ultimately your goal is to get funding. And I'm here to suggest where you can find the money to pursue your research dreams. So next slide, please. So the research funding opportunities are in the UK, and I appreciate that we have people of different seniority. Let's say we have medical students. I'm sure we have foundation doctors, and may have more senior doctors. But ultimately, the things that you're looking for are NIHR fellowships. So these can be pre-doctoral, doctoral, postdoctoral. Academy of Medical Sciences has starter grants that can help you sort of provide you with seed grants to take your work off. MRC is a natural progression. Wellcome Trust follows that. But really, at your stage, you should be looking, and I'm going to put on my Royal College of Surgeons hat shortly to say that the RCS actually offers a lot of research opportunities for more junior people, including research fellowships and pump priming grants. And then obviously within the associations of your subspecialties, as in my case, the SPNS, the BMA will also have grants, and also there are charitable and institutions that offer funding opportunities. Next slide, please. So how to approach the funding application. So it's important, and both Val and Laura has said this, finding mentorship is crucial in succeeding in surgery and in succeeding in academia. No one really can do this alone. And no one in fact does it alone. So there's always a degree of mentorship. And try and find a supervisor early, align with active research groups, try and be helpful to people. Ask and have, I would say, be shameless and ask for people for their applications. Try to learn from other people's mistakes, trying to learn why some people succeed and others don't, emulate the examples, and take feedback, and be humble enough to seek feedback and take that feedback, and practice interviews. Next slide, please. So I've outpaced myself as usual. So I was going to say I'm a member of RCS Council, and that's me with my proverbial RCS Council hat. Next slide, please. And by wearing that hat, so this is another movie that all of you are probably, again, too young to remember. This is The Life of Brian, which is an excellent movie. And at this point, someone says, "What have the Romans ever done for us?" Which is a common question that that the surgical community asks. What has the college done for us, or what does the college do for us? So next slide, please. So what is available to you, or what the RCS can provide to you at a more junior level is an affiliate membership, and you can access advice, educational resources, portfolio to help you with portfolio boosting. And voila, here we are having our webinar. So you want to be a surgeon, so which you're already enjoying, hopefully. They have courses, forums, training days, surgical societies that can help you. And this is, as Val was saying, this is not a sprint. This is a marathon. It is a climb, and then there will be ups and downs. And it's important that you look after yourself and your well-being. And college offers support with that. So don't be afraid to reach out. Next slide, please. Another thing that I would say. So what was also important for me in my sort of pathway or in my career in progressing through several stages of my career is that I joined the Emerging Leaders Program a couple of years ago, and this is a fantastic opportunity. And Laura is saying it's important that you go and try and find or people that look like you or think like you, or you align yourself with them. I think that's not necessarily always possible. But always be mindful that you have your own skill set, and you have your own your own, let's say, unique selling point that you bring to the job, and you should be proud of it and you should own it. So and the Emerging Leaders, sort of like, for me, it was very interesting experience, because I really found very like-minded individuals. And it was great. And when you hear other people who have been through the same experiences as you have, that's quite heartening. And actually, it was actually quite a fun day out. So I really recommend the program. It's a very good opportunity. So next slide. So I would say that basically this is a long flight, and for me there's been a lot of night flights, in the sense that I think people have a sense that pursuing academia is the sort of chilled version, or the chilled sister of surgery. That's not been my experience. Okay, so there's going to be a lot of night work, a lot of awake hours, a lot of extra hours. And I think research for sure amplifies your surgical career, but it's a labor of love. And I think you should do it if you love your research question, if you love your topic, then I think you should fully embrace it. If it is more of a sort of tick box exercise, I wouldn't necessarily pursue a formal degree like a PhD. I think I would advise it to follow a PhD if you love your topic, if you have enthusiasm for your topic, and if you want to contribute in whichever way you can to the science in that topic. And one thing that I would say, being an IMG, which I am, is a strength. I try to think of myself as a citizen of the world, and I think having a global perspective matters. And I think you enrich the life of the hospital and the lives of hopefully of your patients, by bringing that diversity with you. So next slide, please. So I finished my presentation with a René Magritte painting, and there's a lot of dark gray white men raining, and we hope to make the landscape a bit more diverse by having seminars like this. Thank you.
That was great. Thank you, Francesca. I love the movie references, but I thought they were all completely relevant, and it's not because I'm old. I think that was definitely what the equivalent film quotes would be these days, really. I'm not sure Avengers have quite the same impact as Jerry Maguire. Brilliant. So I'm just going to hand it over now to Shri, who's going to give her story of her journey and some talks and tips about support networks.
Thank you, Laura. Such inspiring talks, and I completely agree with Francesca. I don't feel old at all. I recognize all those movies. Right. Thank you for inviting me, first of all, and good evening, everyone. And thank you for joining us today. I'm a consultant colorectal surgeon. I'm also the deputy chair of the Royal College of Surgeons Women in Surgery Forum, and I'm one of the current RCS England emerging leaders. I'm the elected chair on the ACPGBI, which is the Association of Coloproctologists Early Years Consultant Network Committee, and I'm also the mentorship lead. And I sit on the Guidelines Committee, and I'm an elected member on the ASTDI EDI Committee. Next slide, please. Today, I'd like to talk to you as to why surgery remains one of the most exciting and fulfilling careers that you can choose, and how we can support you in this journey. I'm an international medical graduate. I came to the UK less than 20 years ago. I fell in love with the man I'm married to, and that's the journey I took of thousands of miles to be here. I was lucky enough to get into a foundation program in the Mersey region within a couple of months of me coming here. I completed my MRCS as an F1, decided that I wanted to have a family when I was young, took maternity leave of nearly 2 years as an F2, then home was in London, managed to get a co-surgical training job in Northwest London, then decided I wanted to do a period of formal research, which I did at St. Mark's, supported by the college, for which I was awarded a PhD from Imperial College. In the first year of my PhD, I supported myself by working as the lead undergraduate teaching fellow at Imperial College, which opened up many, many doors for me to continue with formal medical education activities even now. I then went on to secure an ST3 number in Northwest London and also served as the general surgery trainee representative. Attained my CCT. I was awarded the Trainee Coloproctologist of the Year in 2022 and did less than a year of post-CCT fellowships, and I'm now in my second year as a substantive consultant. And this surgical journey has been anything but easy. I've had numerous setbacks, both in personal and professional life. I was told that surgery may not be a career option for someone like me. And when I was pregnant, I was told that with a baby on the way, maybe I should choose a career which was better suited to having a normal-ish family life. I was told that surgery is highly competitive and that it would be very difficult to get into a training job. And I think very early on, it became very clear to me that having started working in the NHS, I essentially had two options. I could either feel sorry for myself, be the victim, and give up my career aspirations, which I had nurtured for a very long time, or I could rise to the challenge, break the barriers, and show the world that I belong here too. And that's exactly what I chose to do. I didn't see many people who looked like me in surgery. And I decided very early on in my career that I should play a very small part in to help change this for everyone. Next slide, please. As you've seen from Laura's talk, you're spoiled for choice as to what type of surgeon you want to become. And there are 10 recognized surgical specialties, all of which will provide you with different challenges and rewards throughout your career. I grew up in a family of physicians. I still am the only surgeon, the black sheep in the family. And I was drawn to the dynamic atmosphere of surgery and the sense of camaraderie that comes by being part of a team. For me, the diverse pathophysiology, the extensive array of surgical techniques to master, ample opportunities for research and innovation, colorectal surgery has been the ideal specialty to establish a successful and fulfilling career. But surgery is dynamic, and there's room for every personality and passion. Find what makes your surgical career uniquely yours. Next slide, please. This is for the benefit of the more junior members who have joined us this evening. We surgeons divide our time between a variety of activities. We operate and we love what we do. We love operating on emergency and elective settings. We do ward rounds, looking after patients pre, peri, and post-op. We carry out outpatient clinics where we review patients, a ton of administration work, writing to the GPs, patients, colleagues, addressing some complaints, just to name a few. And many of us take up additional supportive work, which is volunteer roles to support teaching, research, and development of surgery. And you've just heard from Francesca how you can grow up to become an academic surgeon. Next slide, please. So many, if not all of you, would be familiar with many long-standing myths attached to surgery, such as surgery isn't for women, there's no work-life harmony for a surgeon, surgery is too competitive. The truth is, surgery is evolving, flexibility is achievable, and competition only reflects value, not exclusion. We are seeing more women, more flexible training paths, and a culture change that values well-being. So with the college, you and me will be changing the face of surgery. Next slide, please. The landscape of surgery is definitely changing slowly. In 91, we had less than 3% of the consultant surgical workforce in the UK, which was made up of women. Now we represent 17% of the consultant surgical workforce, nearly 30 years later. This is small progress, but progress nevertheless. Next slide, please. I'm proud to call myself a fellow of the English College, which has the highest number of elected members onto the council who are women from a diverse background, as you can see here. Next slide, please. You've heard from Val and Laura, as well as Francesca. You can either have a linear or a non-linear pathway. Doesn't really matter. You may have career breaks, which are planned or unplanned, but my advice would be plan early, seek mentorship, start building your portfolio from the start, even as a medical student. It's competitive, but achievable with focus and support. And please don't just tick boxes. Seek experiences that will genuinely help you to develop as a surgeon. The journey will definitely challenge you, but it will also reward you in ways that few other professions can. Next slide, please. So becoming an expert in operating, that's what we do as surgeons. That is part of the job. So explore other opportunities beyond the operating room, which will make your surgical career a lot more rewarding and fulfilling. Reach out and seek out research opportunities. If you're an F1 and you have medical students assigned to a unit, set up some formal bedside teaching programs. And as you grow through your clinical and surgical career, ask you to become a mentor to someone a bit more junior to you in their career. If there's nothing like a formal teaching program within your trust, set one up. And for medical students, if there are no committees like surgical clubs or societies where you're studying, seek out to set one up. And if you don't know how to do that, seek for help, advice, and support how to run these things. Learn how your department works. Learn how decisions are made at the trust level, because you would want to aspire to become the clinical leaders of the future, driving positive change within the environments that you're working in. It is a network of opportunities that you'll be posed with, and your surgical career can evolve and expand with the interests that you have. Next slide, please. As part of the Women in Surgery Forum, we have set up the Inspire workshops, which used to be called the 30 Schools Project, where we go and give talks to children in schools from underprivileged backgrounds, where we intend to inspire them to aspire to have a surgical career in the future. This is one such workshop I ran in June in Presby Manor School, and each of the volunteers you see in the picture there are all my trainees. Next slide, please. We ran a similar workshop in Birmingham last year, and it's heartening to see such positive feedback that we've played a very small part in helping these people aspire to become future surgeons. Next slide, please. You've heard from Francesca the support networks that are available. Do sign up if you're a medical student or a trainee to become an affiliate member, because this will give you access to advice, resources, and opportunities to help you stand out from the crowd for just £15 a year. And being an affiliate member demonstrates your commitment to surgery in both your core and foundation applications. It will give you access to a variety of study materials as well as discounts at courses, and you can apply to bursaries, awards, and research fellowships. Next slide, please. Become a part of ASSET. Now that Val is here, I will mention that also sign up to become a member of the Women in Surgery Network. It's not exclusive to women, it's open to everyone. And each of the 10 surgical specialties have their own associations and societies that you can sign up to be part of. And the Royal College of Surgeons, we've launched the mentorship platform. There are nearly 300 mentors who've signed up. So do sign up to become a mentee, and you will be matched with your mentor of your choice and desire. Okay. Next slide, please. Following the Kennedy recommendation, the college is working tirelessly to meet these recommendations so that we support surgeons from a diverse surgical background. Next slide, please. And remember to lift as you climb. Make the pathway a little bit more easier for someone who comes after you, because leadership isn't about hierarchy. It's about visibility, advocacy, and lifting others. It's about creating space for others to thrive. To me, mentorship has been one of the most rewarding parts of my work, because there's nothing more rewarding than seeing your mentees thrive. I love this quote from Ria Liang. We can and we should make everyone, no matter their diversity, feel like they belong. Because it's only when they feel like they belong can they thrive. Next slide, please. And as you've heard from all the speakers today, no one does this alone. It takes a village to raise a surgeon, and your support networks will sustain you through the challenges that you face and shape your success. This was at the Women in Surgery Conference less than 2 weeks ago, fantastically supported by the Women in Surgery Forum members. On the top right, bottom right is the Winspire workshop from at Birmingham last year. Top left is a brilliant group of women who are part of the current Emerging Leaders cohort, who form a very good support network for me as an early years consultant. Bottom left, with the help of a colleague, I've developed the After the Scalpel workshop, which we'll be launching on the 7th and 8th of November, which is next week. This is a new program supported by the college to help and support surgeons who've had to take a career break and who are returning to surgical practice. Next slide, please. So how can you engage with us? You've heard there are loads of opportunities that are available to you. First thing to do is to get onto the college website and learn more about careers in surgery. Next slide, please. The future is definitely in your hands. Explore the opportunities, ask for help and support, and believe in yourself, because your background, your experiences, and your individuality do belong in surgery, and don't let anyone tell you otherwise. The moment you believe you belong in surgery, you already do. And I hope you can walk away today knowing that you can be a surgeon and that we are here to help you in that journey. Next slide, please. And lastly, this is something I picked up at a webinar I attended a few years ago, and it has stuck with me. Be so good, they can't ignore you. Next slide, please. And these are various ways that you can be connected with the college. This picture is from the Emerging Leaders Celebration event in May this year. Next slide, please. Thank you for listening.
Thank you so much, Shri. This has been very inspirational, actually. It's really interesting to hear how people have wound their way through the surgical pathway. I realize it is quite lady heavy and women heavy today. You are still allowed to be a surgeon if you are a man or a non-binary person, but I think it's sometimes nice when all the press and the stories you hear always tell a certain story. It's quite nice to see that it's not black and white, and there's not only one way to become a surgeon. And I think what we haven't mentioned enough really is how good it is, how much fun it is, how exciting it is. It's a challenge, it's hard work. We have to know the anatomy inside out. We have to know the science inside out. We have to keep up to date. We are, it's a privilege. I think Francesca mentioned it. It's a privilege to create a relationship with a patient where they will allow you to put a knife in them, that they trust you. So I think one of the questions that we received beforehand was somebody interested in psychology and psychiatry. And there's a huge element to being a surgeon of developing a relationship with a patient, understanding their wants and needs, understanding what risks they are and aren't willing to take and what matters to them. And it can be very complicated and tricky sometimes to not operate on someone or to not do what they think is an easy option. So it's not a black and white thing, surgery. It's not just you need an operation, we'll do it. There's a relationship between you and the patient. And I think that's becoming more and more apparent. I think maybe in the olden days, there was a bit of a situation where the surgeons would tell a patient what to do and there wasn't back and forth, whereas it's completely changing the face of surgery going forward. It's a two-way street, and we do develop relationships with our patients. And it's very different, I think, now to what I looked at when I was going through training. So I think the more you attend surgery, attend clinics, attend ward rounds, and see the life, the more you'll understand whether it's something for you or not. Thank you very much, everyone. I think we've been trying to keep on top of the questions in the Q&A. I think there's a few bits and bobs about bursaries and funds, which I'll let the Royal College admin people answer, but there are loads of bursaries. I did an elective in Hong Kong, and I wrote to the college and said, I want to go to Hong Kong and I haven't got any money. And I was awarded the Darlow Travelling Fellowship. So there are lots and lots of options for you. You've got to research and find them out, but the college are really, really supportive for bursaries. We have been sent some questions before the meeting, so keep adding your Q&A questions and I'll look at them again in a minute. So some questions we were sent beforehand. What can we do now to improve our CV? I think Val probably answered that. It's research, audit, leadership, teaching. Even if the titles and the wording changes, these are the things people want to see. They want to see that you're driven and that you're trying and you're making an effort and you're improving things. They want to see you'll be a good doctor and a good colleague. Who would you want to work with you in your department? It's not someone who just does the bare minimum. It's someone who improves the clinics, improves the services, does research. So think about who you would want to be in your department, and that's who you need to show in an interview. Do you have any advice for finding mentors or research career guidance? So any tips for finding mentors, ladies?
I would just reach out to anyone you're working with to start off, because you'll realize people are just waiting to be approached, and there's no harm. They can either say yes or no, or they could direct you to someone else. That's what I did when I came to this now. I knew no one, and I just wrote to, I would think, around 30 to 40 people on the Women in Surgery network, and a few of them got back to me. Some said they could help, others said they couldn't, but they helped me to put me through to someone else who could help. So that's what I would do.
I think it's important to realize as well that even if you are a woman or a minority in surgery, you don't have to find someone who matches you to be your ally and your mentor. So men can be just as good allies and mentors for women, and actually they probably might know more of the routes or have a network already set up that can help you. So don't feel obliged to try and find the one orthopedic female surgeon in your hospital, for example, because she's probably got all the other medical students to talk to as well. So the few people who look like you, if you are a minority, are probably quite busy already. So don't feel like you have to find someone who matches you to support you. You just need to find someone nice that you get on with. And I think the easiest way to do that is to just say, I'm really keen. I want to do surgery. Do you have any research? Do you have any audits I can help with? And then be useful, not just disappear and not answer emails. Keep up with people, and they will value you, and you'll create a relationship. This is an interesting one. Is age likely to be a problem in being offered a surgical training position? Do you think there's a life stage that would be considered too late to enter surgical training? Does anyone want to answer that one? It's quite hard, that, actually. So at ST3 level, age is not a factor. We don't look at that at all. In terms of appointing, we look at papers, audits, scoring, the answers to questions, clinical knowledge. However, the logistics of operating, as you get older, can be a factor, especially in orthopedics where you're belting things with a hammer. I don't think you could be doing that at 70 years old. So I think you probably would have to be sensible in terms of a speciality you went into that would be less physical. I'm not sure if anyone else has anything relevant to their specialty.
I think everyone's journey in surgery is so different. And now there's so much more flexibility in terms of being able to go less than full time and choosing the subspecialties that may work best for you. So I wouldn't say necessarily that your circumstance, your age is a limiting factor if you want to pursue a career in surgery. If it makes you happy, go for it, and you'll find people to support you, and you'll be maybe the champion of someone who's doing something different. It can be a bit harder, I'm not going to lie, because it can be long hours, but everyone's journey is different. But if you want to go for it, go for it.
And as we said, there are always routes you can take. If the job did become too physical, as Francesca said, more academic routes, more research, more mentoring. So I've been a consultant now for I think about 6 years, and the first few years is just operating, trying to get your head around the clinical and trying to feel comfortable and not panic when you go to theatre and have to revise everything. But now I'm getting more into management. I'm spending all my times organizing clinics, looking at service provision, capacity, demand data, and I'm organizing teaching, and I'm organizing conferences. And actually, sometimes you can wind away from surgery when you become more senior. So there are lots of routes you can go down once you become a surgeon, if you find it's too physical or you're getting a bit old for it. So I wouldn't let that be a barrier. I think do it because you love it, follow your heart, and the rest will come with time. Looking here, I think we've answered quite a lot of these questions about portfolio, scoring. As a college student hoping to become a surgeon, what experiences or habits should I focus on now to best prepare for medical school? And they mentioned shadowing. Yeah, our hospital does shadowing for college students and medical students. It's normally about a week, and you get given a little template, and you just get your little badge. And you walk around and spend time with the surgeons. Any experiences or habits that you guys can think of for college students?
I think the number one habit is reliability. Whatever it is that you put yourself forward to do, just deliver. And it could be something small. Show interest and be helpful and be consistent and be reliable and be mature. Okay, I think showing maturity and commitment, even if you're still in an exploratory sort of phase of your career, if you show up and within your level, you show up prepared and you have an idea of what it is that you'll be doing on that day of shadowing, and you try and be helpful and you try and be polite and you treat everyone well with respect, that sort of makes a mark, I think. And keep those habits. And these are basic human sorts of competences, but keep those habits and you'll probably sort of shine among your peers of maturity, sorts of reliability. I think these are good habits.
So thinking back to the medical students, that we get a lot of medical students down in Brighton, we're attached to a medical school. If the medical student is excited and going, oh my God, that's a nerve, that's a tendon, I want to see it, can I scrub? And then you teach them how to scrub. And that energy, that excitement is so lovely for us, because sometimes we can get jaded and tired doing the same operation over and over again. And it really energizes people to see someone coming in with excitement about surgery. So we love answering questions. The nurses, if the surgeon's busy, go to the nurse and say, what's this called? What's this called? What's this machine do? We really love to see interest and excitement and to teach. All surgeons love to teach. So ask questions, be energetic. If you come to see a carpal tunnel decompression, if you've read up about carpal tunnel decompressions and can convince me you've read up, I will let you cut the skin. I will let you put stitches in. So if you are willing to read up and convince us that you're safe and convince us that you care and that you'll be careful, you get to do a lot more, and you'll get a lot more from the experience. If you're just stood at the back of theatre waiting to get signed off, I've been to theatre, sign me off, you're not really getting anything from that. So throw yourself into it, get to know people and get yourself scrubbed in, and you'll learn very quickly whether it's for you or not, I think. Just going down here. There's a question here. Maybe Val can field this one. Do you see any benefit of CST over the CREHST form for certain specialities? So, for example, urology needs maximum portfolio points.
I think all of the higher surgical training posts are highly competitive, and they require different things. Having gone through plastic surgery application process, which requires lots of experience in hand surgery, um, nerve tendon repairs, burns management, all sorts of things, skin cancer, you have to have operative evidence. So it's a lot of work. But I think whether you choose to go the standard core surgical training route, or if you choose alternative posts, you may have seen that some of the hospitals sometimes even offer equivalent training programs to CST for people who may have not been able to get into core surgical training or choose to go in the different pathways. There's pros and cons to that, and I cannot guarantee that it will get a certain candidate quicker to an ST3 post or no. I think it's more to do with the commitment and actually being focused towards your specialty and what the application needs are, and actually in the long run, what makes you a good and safe trainee and a surgeon and easy to work with for your peers and consultants. So I don't think that there's a huge disadvantage whether you do CREST or CST. I think CST is more streamlined and you're more protected by the existing framework and the systems and the pathways of escalation and so on, in terms of going to who's your local TPD. If there's a huge issue, obviously going first year educational, clinical supervisors. And if that doesn't work, and there's certain ways of how certain training posts are, how successful they are monitored, how well trainees perform in their exams, are they able to progress into ST3 and so on, the training surveys. But there's no right or wrong. For every person is very, very different. And there's benefits of choosing alternative pathways because you may be able to stay in the same trust for 2 years. Some of these CST pathways don't offer that, but it's all about persevering and going for what you like.
Yeah, I agree. So at the ST3 level, registrar level, there's no difference. It's not a factor what route you took. We care about evidence. So presentations, papers. And I wanted to amplify what you mentioned in your application. Please do not send 400 audit slides when you're applying to things. It's no offense, it's the most boring thing in the world. So in orthopedics, we have 600 applications and we have to look at all. Just give me a certificate saying, I did an audit, I presented it. That's all I don't need to see every single audit slide. And it takes days and days, and there's 30 of us doing it for days and days and days and days. And we get tired, we get bored, we get annoyed because we're human. So follow the rules, look at the website, look at what you can and can't include. Don't try and take the mickey. That's the other thing that annoys us as well. And we've actually started having a special score for organization now. So if you're all over the place and we're wasting hours and hours and hours getting annoyed, we take off a point for organization. So be really clear, run it through with a friend, ask a consultant if this looks good, does this look okay? And try not to annoy people who are volunteering and giving their own time to be part of this process. So the people who are volunteering are here out the kindness of our hearts. No one's getting anything for it. And we want to find nice people as future colleagues, but it can be quite soul destroying when you have 5,000 audit slides and you have to try and find some evidence that they've presented an audit. But it'll always be the same evidence. It's the same things: audits, presentation, publication, leadership, teaching, management. And everything you do outside of your curriculum, you can find a way to tie that into a certain selling point, I'd say. Francesca had to leave because she's on night, so it's very kind of her to come because she's starting work in about 10 minutes. Thank you so much to my speakers. I can't see any more new questions appearing. There's been a few more that have been answered by the college team. If you actually have a look in the question and answers section, there's been a lot of information uploaded there, particularly by Val, about all the different websites and all the scoring for all the different CST things. I think all of this is available to watch later on at your own leisure. And also everyone's sent a certificate of attendance as well, which is another thing to add to your little CV stash that you need to start collecting. Thank you so much for my speakers. Thank you for giving your time. Thank you for Francesca, who's already gone. And thank you, Val and Sri. That was really, really interesting and really lovely to hear. Well, I hate the word resilience as well. Determination, we'll say determination to get where we are. I think we'll all agree surgery is amazing. And if it's for you, then follow it with passion. And we hope to see you all in theatre very soon. Thank you very much for coming.
Thank you.
Thank you. Bye-bye.
Bye.